Okay, and welcome to our session on chronic obstructive pulmonary disease and asthma. So hopefully you've got a good idea of what's going on when we're thinking about lung function in health. Now we're going to start thinking about what goes on in disease states. So obviously we're looking at two major obstructive lung diseases in asthma and COPD. We're going to focus on what's happening in the airways, what symptoms arise from those changes in the airways, and how these conditions actually differ. So at the end of the session, we want you to be able to think about the underlying mechanisms of asthma and COPD and understand why they cause the symptoms that patients experience. So that's really what we want you to be getting at the end of this session. So obstructive lung disorders. So we classify lung disorders really as obstructive, where there are blockages to airflow, and restrictive, where there's restricted airflow. We're not really going to, or at all actually, going to talk about restrictive lung disorders. That's for another year. We are going to talk about obstructive lung disorders, where the main difficulty is getting air out of the lungs rather than in. So there is a difficulty in getting air in, but the real significant difference is getting the air out. So any of you with asthma will know that exhalation or blowing out tends to be much harder than inhalation. And that can happen because the airway is physically narrowed, or because the lungs have lost their normal elastic recoil. So there are a couple of reasons why this can potentially happen. When we're thinking about each condition, there's increased resistance to airflow. And that, like I said, might be a complete obstruction, which is really nasty, or a partial obstruction. And that can be at any level, from the trachea up at the top of the airways down to the terminal and the respiratory bronchioles much further down into the respiratory zone. And that expiratory obstruction, it can be due to anatomical airway narrowing. So that might be bronchoconstriction, so closing of the airways, or it might be because of the loss of elastic recoil of the lungs. So there are a couple of things that really give the potential reasons for it. When we're thinking about obstructive lung disorders, we're thinking about emphysema and chronic bronchitis, and the two of those together make up the chronic obstructive pulmonary diseases. And COPD, these are usually come from or occur down to long-term irritant exposure, most commonly smoking, but also things like dust, chemicals, or indoor or other outdoor pollutions. And if we're thinking about the two conditions here, you can see chronic bronchitis causes a persistent wet cough, if you want to think of it like that, okay, because you have an excess of mucus production and inflammation. While emphysema, as we can look at this, it destroys the membrane walls. So you can see here's a nice healthy alveoli, and here you can see the alveoli walls are disappearing. They're going to get damaged, they lose their recoil, and their structure, but at the same time they're losing surface area as well. So that gas exchange isn't as effective. And asthma, and so these are chronic obstructive pulmonary diseases which aren't reversible. Asthma obviously is kind of an acute condition. So you have episodes of asthma, though you may have it chronically over the longer term. It does lead to permanent airway changes, just like COPD does. But obviously, there are a variety of drugs that help to relieve that. So if in both conditions we're having issues with obstruction or difficulty getting air out of the lungs, so in other words, if the airway resistance doubles, so the airflow rate changes because of that. But if our airway resistance doubles, how will a patient compensate? So I just want you to have a little look at this. Airflow rate is equal to the pressure gradient, and we've covered that when we talked about inspiration and expiration, divided by the airway resistance, which is just by the diameter or the radius of the airways. So if the airway resistance doubles, because you might get bronchoconstriction, you might have lots of mucus or inflammation, what will happen to the airflow rate, and what will a patient have to do to compensate? Okay, so if the airway resistance doubles, to maintain the same airflow rate, the pressure gradient will also have to double. And what that means, of course, the patients will need double the pressure they generate to move the same amount of air. So breathing becomes much harder work. And in fact, they can fatigue as if this is over an extended or prolonged period because of that increased pressure gradient that they're having to generate to cause the same or allow the same amount of airflow rate to occur. So a key question is, I kind of alluded to it earlier, why is breathing out much harder in obstructive lung diseases than breathing in? Now, don't get me wrong, breathing in is slightly harder, but breathing out is much, much harder. So again, I want you to just press pause. Don't look at the slides because you'll have the slides in front of you. Don't look at those. And I want you to think, why is it harder to breathe out, in particular in obstructive lung disorders? So remembering what happens when we breathe in. So when we breathe in, that causes the outward motion of the chest wall and expansion of the lungs. So the chest is expanding and the airways naturally widen. Even if they're constricted, we're still pulling them open. Okay, so they are getting pulled more open. So therefore, you are still able to get air in fairly effectively. So the airway diameter increases and air can enter the lungs. Exhalation, on the other hand, causes the airway diameter to decrease. Now, in the healthy lungs, that small narrowing doesn't really matter. Okay, it doesn't make any difference to airflow rate. But in asthma and other obstructive pulmonary diseases, the airways are already potentially inflamed and constricted. So when you breathe out, they narrow even more. And in severe cases, they can be so narrow they can even close shut and briefly collapse. And so therefore, that is why that exhalation is more difficult. They're already constricted due to inflammation and bronchoconstriction. Then you're breathing out and they narrow even further, meaning it's really hard to get the air out. And like I said, sometimes they collapse altogether. And if they do collapse altogether, this traps the air within the alveoli themselves and makes exhalation really, really slow and really, really difficult. So that's why you get that kind of wheezing, trying to breathe out the air. And it's really, really difficult with that trapped air and those inflamed airways and those bronchoconstricted airways. So now we're going to think about asthma. Okay, so we'll look what is actually driving asthma symptoms. So remembering what it is, asthma is a chronic inflammatory disorder of the airways with acute exacerbations. So you're getting intermittent airway obstruction due to resistance, and it's caused by several factors. So the three main factors, you've got bronchospasm. So basically, whatever the trigger is, and we'll talk about triggers later, you get excessive smooth muscle constriction of the bronchi, causing to bronchospasm or bronchoconstriction. You get airway wall thickening. So inflammation is occurring during that response and histamine-induced bronchial edema. So you've got inflammatory material there and you've got swelling there. So you've got edema building up as well. And then you've got excessive amounts of mucus are secreted by what are called goblet cells within the bronchi as well. So you've got all three. And these three combine to create both a variable and intermittent obstruction, giving those classic symptoms, okay, of a wheeze, breathlessness, chest tightness, and a cough, which is often worse at night, and in particular after triggers. And like we said, severe clogging of the airways can completely stop airway flow in extreme cases. So here we've got a normal airway, and on the left-hand side, okay, so you can see the nice open airway. You come into an asthmatic airway after kind of a bit of adaptation and over the years, and you can see there's increased wall inflammation and the increased number of goblet cells and increased amount of mucus. And then during an asthmatic attack itself, you can see on the far right, you can see the tightened smooth muscles. So you get bronchoconstriction, closing off that airway even more with increased mucus, increased secretion of mucus from the goblet cells, and increased inflammation. And like we said, severe clogging of the airways can completely stop airflow in extreme cases. And that's when you start to get, on that right-hand image, air trapped in the alveoli. So you get air trapping. So you can't get rid of that air. What about in the long term in asthma? So you do get long-term airway remodeling. And that permanent remodeling occurs due to the chronic nature of the exacerbations. So the continuous asthma attacks, if you want to think of it like that. So over the long term, long-standing asthma leads to permanent structural changes. Okay, that's the key thing. You're getting structural changes in the airways themselves. The smooth muscle becomes thickened, and therefore bronchoconstriction is occurring. It also leads to changes in the airway structure with reduced elastin and therefore elasticity, meaning there is less recoil of the airways, and hence breathing out is affected more than breathing in. The recoil is less, so less air is being pushed out. And in addition to this, that reduction in elastin also means there is more collagen scarring forming, which leads to fibrosis. And again, that is stopping the airways from working properly. They're not able to recoil and expand out and push out to the air. And the other thing that happens is that the epithelial cells under normal circumstances provide a nice barrier to the external environment. But when they're damaged by allergens and toxins, a variety of factors can be released, for example, growth factors, and they drive goblet cell hyperplasia, for example, and that drives inflammation, which is normally protective, but isn't in this case, because you've got all those excessive goblet cells producing loads and loads of mucus and inflammatory material. Because remember, mucus has a function to trap inhaled irritants, but it's not good when we produce too much of it. So even just in mild to moderate asthmatics, they'll find that the goblet cell number is increased threefold compared to a non-asthmatic. So that's a significant amount of extra goblet cells and therefore potential production of mucus. And in addition to the reduced airflow and gas exchange, that breathing becomes harder even between attacks. So you get increased reactivity due to that long-term presence of inflammatory molecules. Therefore, it's much easier to provoke a response. And these permanent changes, and they are permanent, so remodeling isn't fully reversible. Okay, can lead to reduced gas diffusion rates and therefore long-term shortness of breath. And that is why early anti-inflammatory treatment is really important to kind of keep that airway remodeling to a minimum. So again, on the right-hand side at the bottom, you can see a regular non-asthmatic airway. And if you look at the remodeled asthmatic airway, you can see that increase in the amount of smooth muscle present there, the increased thickening and the increased constriction of it. You can see the lumen narrowing with increased smooth muscle, more inflammatory cells, more mucus, and thickening of the various membranes. All of this occurring in the remodeled asthmatic airway. So what are some of the triggers? Well, asthma is influenced by both genetic factors and environmental triggers. And that airway hyperactivity that we've talked about is responsive to a variety of non-specific triggers or non-specific stimuli. So, for example, you have environmental allergens such as pat dander, and so PATS is a very common allergen. You have non-specific irritants, so cigarette smoke, and other toxins that are out in the environment. The variety of food and drinks that will do it as well. There are some upper respiratory infections, so in particular thinking about viral infections, certain medications, so aspirin in some people, and also you get cold-induced asthma attacks. So cold air is a lot more is fairly common as well, or exercise-induced as well. So you can see there are a whole variety of different triggers, and different people are sensitive to different triggers. So what are some of the clinical manifestations? So this is what you can see here is a peak flow meter, and that measures your peak expiratory flow rate. So if you're an asthmatic or even as a non-asthmatic, you want to see what your expiratory flow rate is. You breathe out as hard as you can through one of those, and that gives you your peak expiratory flow rate. But because the airways are narrow during an attack, patients have a reduced expiratory flow rate, which is, like I said, what you will measure on that machine. So asthmatics will often take these home with them and measure their peak expiratory flow rate at various points during the day into a kind of a graph format, which then can be looked to see when the triggers or when the changes in peak flow kick in. And like we said, when you get the closing of the airways, you might get trapped air leading to lung hyperinflation. and patients may develop what's called a barrel chest due to the use of accessory muscles within the lungs. So instead of having to just use their normal respiratory lungs, so the diaphragm and the internal and external intercostals for breathing in and out, they may have to use the accessory muscles on top of this, and they get this kind of a barrel chest look to them. And as we said, the cough, wheezing, thick and sticky sputum, with the wheezing in particular being most noticeable on expiration. And obviously, this leads to hyperventilation and potential tachycardia, which is an increase in your heart rate with that increased work of effort. Like I said, here you've got an image of someone with a normal chest and with a barrel chest. And you can just see that increased barrel chest due to the increased use of those accessory muscles of respiration, which you wouldn't normally see. And then you've got status asthmaticus. So this is a severe episode that doesn't respond to the usual treatment. And that is a medical emergency. Okay, so that's a significant and severe exacerbation of asthma that isn't responding appropriately. And so people be admitted to hospital for that. So when we're thinking about management, and I appreciate that you're not trained to be doctors at the moment, but you do need to think about what is actually happening. What are we going to try and do to alleviate the physiological or the pathophysiological changes that are actually occurring? So remembering what's happening, we're getting bronchospasm or bronchoconstriction. We're getting lots of inflammation, and we're getting excess mucus production. So really, what do we want to do? We want to try and deal with those three things. Okay, and you don't need to remember what the drugs are or anything like that, but you do need to understand the pathophysiology and therefore how we deal with that pathophysiology potentially. So thinking about this, what might you give? So here's a little table: airway narrowing cause, bronchoconstriction, inflammation, mucus. Don't need to know the names of drugs. I just want you to think, what would you give to try and bring the physiology back to normal? So press pause and have a little bit of a think. Some of this is common sense. Some of you may have asthma, so you think this is really, really easy. So have a little bit of a think. Okay, so the problem is with bronchoconstriction, what do? You give a bronchodilator, something that relaxes the bronchi smooth muscle. So you have both long-acting and short-acting bronchodilators, and they tend to be your emergency meds, in particular the short-term ones. So those are your Ventolin. So that's the blue puffer for those of you who know the puffers. So your bronchodilators, short-term and longer-term. Inflammation, what do you give? You give anti-inflammatories. So you give corticosteroids. So they're basically copies of cortisol, which is your long-term stress hormone. Your long-term stress hormone keeps inflammation and your immune system in check. So it just keeps it balanced. And so all we're doing here is we're giving a powerful cortisol, for example, beclomethasone, and that helps to dampen down the immune system and the inflammatory response going on in the lungs. Remember, it's an inhaler, so it's targeting the lungs. But it's also important to remember that when you give an anti-inflammatory and something that dampens down the immune system, you're more likely to get infections, and in particular in the mouth. So asthmatics who are taking corticosteroids will know to rinse their mouth out after they've taken their corticosteroid. And that is to stop the potential, is to wash out the corticosteroids out of the mouth, so you're less likely to get infections in the mouth. Finally, mucus. How do we deal with the excess mucus? Well, firstly, hydration. You want to, if you're nice and hydrated, your mucus is going to be thinner and therefore easier to remove. And then there are drugs called leukotriene modifiers, such as montelukast. Work better in kids than in adults on the whole, but they help to reduce the amount of mucus that is being produced. So just go back to that. So a key thing is that those are the key treatments there. So review question. Have a little read through this question, and then I shall go through it with you. So press pause. Okay, so a 45-year-old male presents to the emergency department with a 3-month history of wheezing, shortness of breath, and chest tightness. His symptoms are worse at night and after exposure to certain triggers. He uses a rescue inhaler inhaler intermittently for relief. What is the single most likely underlying pathophysiological mechanism contributing to his symptoms? So, what do you think the answer is? Hopefully, you put A, airway inflammation and hyperresponsiveness. Remember, asthma is characterized by chronic airway inflammation and excessive narrowing in response to a trigger. So, hyperresponsiveness to a trigger that most people won't have a trigger to. So, the others are obviously incorrect. So, what we're going to do now is we're going to have a little think about COPD. Okay, so remembering there are two COPDs, or chronic obstructive pulmonary diseases. So you've got emphysema and chronic bronchitis. Things that cause them, pretty much the same. Can patients with COPD have both conditions? Yes, they can. Can they just have one? Yes, they can. They may have just emphysema, they may have just chronic bronchitis, or they may have both. Okay, a large majority have both, as you may expect, because the triggers are the same. So when we're thinking about emphysema and chronic bronchitis, this is where the lungs are permanently damaged, causing progressive and long-term airway inflammation. And both are causing that progressive airflow limitation, and it is not fully reversible. That's the key thing here. It is not; these are not reversible conditions. So again, just to remind us, here is your emphysema and your alveoli on the right-hand side. You can see the lack of alveolar structure. And in chronic bronchitis, from its name, it's chronic, and you get a productive cough. Itis, you're getting inflammation of the airways, and it's of the bronchial tubes, hence the bronchi or bronch. So, like we said, emphysema, you tend to get you get destruction of the alveoli themselves, and in chronic bronchitis, you're getting inflammation of the small airways. And like I said, you can get both. So you can often have a combination of both alveolar destruction from emphysema and airway inflammation with mucus from chronic bronchitis, but you don't necessarily always have both. And smoking is the main risk factor. But obviously, pollution, occupational exposures also contribute. Does vaping contribute? Maybe a little bit, but only time will tell on that one. So, if you're thinking about the amount of damage that vaping does compared to the amount of damage that smoking does, if we were to put a very crude guesstimate on it, you'd kind of say that vaping is approximately 5% of the damage of smoking. Okay, so it's a lot better than smoking, obviously. And that's really crude. Okay, the evidence is a little bit is short at the moment, and only time will tell as we start to learn more. But recent evidence suggests it's really a lot better than smoking. So if you're a smoker and you move to vaping, you are having a massive benefit on your health. If you're a non-smoker and you go to vaping, then you're doing some damage. Okay, how much it is, only time will tell. So let's think about emphysema. What's happening? So this is where you're getting abnormal and permanent enlargement of the air spaces distal to the terminal bronchioles. So basically at the ends, they're the alveoli. Okay, you've got your healthy alveoli and your alveolar membranes that start to break down. So the initial or the pathophysiology behind it, you get that irritant exposure. Okay, so you get that long-term exposure to irritating gases or particulate matter, for most commonly from cigarette smoke, but also other air pollutions or occupational exposures. So there are a variety of causes, but like I said, smoking is the main one. That leads to an inflammatory response. So the inhalation of those irritants triggers that inflammatory response in the lungs, and that inflammation leads to the release of a variety of different enzymes from the macrophages, so those are the white blood cells that eat stuff within your alveoli. And one of those enzymes that is released in particular is elastase. Now, this has purpose. It's a defense mechanism, and its purpose is to destroy the irritants that are present in the lung. So there is a reason elastase is released. Unfortunately, with prolonged exposure, it also destroys the lung tissue. And so, remembering, of course, what elastin is, it's a protein that provides elasticity to the lung. So the released elastase then breaks down that elastin, leading to a loss of elasticity in the walls of the alveoli. So the airways can still open up okay, but the elasticity is lost for passive breathing out or passive exhalation. And so as we're leaving all of that structure behind, you're losing that elasticity in the alveoli walls. And that repeated cycle of inflammation and elastin breakdown results in the destruction of the alveolar walls. And as a consequence, the small air sacs fuse, creating larger, much less efficient air spaces. And as the size of those air spaces becomes less, there is a reduced surface area available for oxygen and carbon dioxide exchange, and that obviously impairs the ability to transfer oxygen from the air into the bloodstream and to remove carbon dioxide out of the bloodstream into the lungs for pushing out into the environment. The other thing that happens, of course, is the loss of elastic recoil in the lungs tissue makes it difficult for the airways to stay open during exhalation. And this is all down to the interdependence of alveoli. Remember from an earlier session, alveoli are holding each other open. Okay, so if one wants to collapse, okay, the others will hold it open. They're interdependent. That interdependence is lost, therefore they can snap shut on exhalation. In particular, active exhalation. So if you think about it, you have passive breathing in and out, like you're probably, hopefully doing right now, or you can have active exhalation, whereas you force a breath out. So forcing that breath out, they're much more likely to snap shut on active exhalation. And as a result, air becomes trapped in the damaged alveoli, leading to hyperinflation of the lungs. And of course, as you'd expect with all of this, there's an increased work of breathing, because and with the reduced efficiency in gas exchange and increased air tracking, individuals with emphysema experience really shortness of breath, difficulty breathing, leading to those coughing, wheezing, shortness of breath symptoms. So that's emphysema for you. Now we're thinking chronic bronchitis. Remember what this is? You have a healthy lung and you have a chronic bronchitis airway with a buildup of inflammatory material and excess mucus. So just like in emphysema, chronic bronchitis is often associated with long-term exposure to irritating gases and particulate matter, most commonly cigarette smoke. That obviously leads to chronic exposure of those irritants, triggers an ongoing inflammatory response in the airways, activating a variety of immune cells and the release of a variety of inflammatory molecules. And one of those is that irritating, leading to hypersecretion of mucus by goblet cells. Remember, the goblet cells are the cells that make the mucus. And this excess mucus is a hallmark of chronic bronchitis. Excuse me. So as well as that chronic inflammation leading to hypersecretion, that irritant exposure causes ciliary dysfunction. So the cilia, which normally take away the mucus and all the nasty particulates that are present in it, no longer work as well. So we can't clear the mucus that is being hypersecreted, leading to even more airway narrowing. And then, of course, you've got that inflammation that we've already talked about. That is also leading to that increase in swelling as well. So overall, you're getting a massive increase in the amount of mucus that you can't clear. You're getting that inflammation. You're getting the cilia that are failing. And the mucus, because it's not clearing particularly well, goes deeper into the lungs. And as it going deeper into the lungs, that's what's giving you that productive cough, that excess mucus that you're getting. But like I said, as it goes in deeper in, the chronic inflammation of mucus creates an environment which is bacteria absolutely love. So that leads to recurrent respiratory infections, which further exacerbates the symptoms. So overall hallmarks of chronic bronchitis, excess mucus, that is a key feature of it. Okay, you get that excess mucus with a persistent cough that is called a productive cough because you're bringing up that mucus and phlegm and gunk with it. Again, leading to SOB, so that's shortness of breath, and again with your difficulty in breathing. It is important, like I've already said, is that emphysema often coexists with chronic bronchitis in COPD patients. Okay, so when we're thinking about COPD, again, it's nice just to think. I know we don't need to know about the drugs as such and the treatments as such, but it's important to understand the principles behind it. We can't reverse the structural damage that's being done in COPD, but we can slow progression and improve quality of life. And that's what treatment focuses on. It focuses on symptom relief, preventing exacerbations, and managing other related conditions. So giving up smoking, absolutely key. Antibiotics for frequent infections, anti-inflammatory meds to dampen down the inflammatory response. Inhalers, so bronchodilators to help dilate the airways wherever possible. Vaccinations, for example, influenza to reduce the infections, so the respiratory infections that you get, and then the more significant pathways into oxygen therapy and lung surgery as a last resort. So here is a question for you. So I'd like you to press pause and have a little bit of a read. It looks like I haven't read it for ages. It looks like a very long question. So have a good read, have a think about it, and then we'll go through it in a second. Okay, so a 55-year-old man comes to the clinic with shortness of breath and a persistent dry cough that has worsened over the past 4 months. He's a 30-year history of smoking, long smoker. On examination, he's decreased breath sounds in the lower lungs, difficulty breathing, especially during activity, which explains the change in his lungs that are causing his symptoms. So is it A, B, C, or D? So the answer is B, destruction of the alveoli and loss of lung elasticity leading to difficulty exhaling. So this patient's his symptoms and history are most consistent with emphysema. So remember, long-term smoking, he's got that smoking history. And in emphysema, the alveoli, those little air sacs in the lungs, are destroyed and the lungs lose their elasticity. So therefore, patients struggle to breathe out, leading to shortness of breath. First one, let's have a look. What's that? Thickening of the airway walls and increased mucus. So it's a dry cough. So you know it's not increased mucus production. And that obviously fits chronic bronchitis. So the first one is chronic bronchitis, which he hasn't clearly got in that. B is emphysema, which is what he has got. C, what's that? Scarring of the lung tissue, leading to stiff lungs and a reduced ability to expand. That is a restrictive lung disorder called pulmonary fibrosis. That's where they get stiff, non-compliant lungs, so that they're difficult. Non-compliance is about the ability of the lungs to expand. So they're non-compliant, they can't expand out. Okay, so often environmental factors will lead to pulmonary fibrosis. What's the next one? Inflammation of the small airways leading to temporary narrowing. That's obviously asthma, and fluid buildup in the lungs leading to breathing. So that's obviously pulmonary edema. So buildup of fluid in the lungs can be caused by heart failure, for example.